Great. So thanks everyone for joining in. So we're going to talk about curative liver transplantation for HCC beyond conventional criteria. Okay. So as you know, in our country and pretty much all over the world, but much more so in our country, despite the surveillance programs for high-risk patients with cirrhosis, hepatitis C, B, alcoholic liver disease, and MASLD, majority of our patients still present with advanced HCC at the time of diagnosis, and they're often non-resectable and non-transplantable, right? This whole dream of early HCC, single lesion or less than 3 tumors, less than 3 centimeters, these are possibly just 10% of the presentations. Majority of the patients present with multifocal HCC or vascular involvement. So let's deal with this group where you have multifocal HCC beyond conventional criteria or vascular involvement. Okay, so now we all know the Milan and UCSF criteria, where single tumor less than 5 centimeters or 3 tumors each 3 or less centimeters, or a single tumor in UCSF less than 6.5 or less than 3 nodules, less than equal to 3 nodules, each less than 4.5 with a total tumor diameter of 8 centimeters or less, give excellent survivals in the region of 75 to 80% at 5 years. These were published nearly 30 years ago and 20 years ago, respectively. And these have come to guide transplantation guidelines across the world until recently, when the dogma seems to have changed. So we are moving from size and number and Milan and UCSF and just worrying about survival after liver transplantation, which is utility, to size, number, and tumor biology. And instead of just survival after liver transplantation, we're talking about transplant benefit, which means the incremental benefit in survival with transplantation compared to the best non-transplant option. And of course, tumor biology, along with the size and number, dictates majority of the selection criteria across societies, and not just within our hospital system, but literally across the world. So now let's look at this multifocal HCC as the first case of locally advanced HCC that we're going to deal with. And now, what is the experience of expanded criteria without extrahepatic spread or macrovascular invasion? So we're just looking at size and number, no extrahepatic spread, no macrovascular invasion. And when within Milan or T2, prior to LT, is transplanted versus downstaged according to UCSF criteria, there is equally good 5-year overall and recurrence-free survival compared to de novo T2. And that's what Francis Yao showed back 10 years ago. And similar experience from Mazzaferro about 5 years ago, where they did a randomized control trial, phase 2B and 3, where 45 patients with HCC with more than 50% possibility of 5-year survival using size, number, and AFP criteria. And downstaging and liver transplant versus no liver transplant, there was 5-year survival of 76% versus 18%. So obviously, downstaging works, right? And similarly, there are now downstaging criteria within UNOS, and the entry criteria for downstaging are single 5 to 8 centimeter tumor or a total tumor diameter of 8 centimeter, up to 4 or 5 small ones with no extrahepatic or macrovascular spread. And out of the half in this particular series, out of half the successful DSs, 31% received liver transplantation. And among the nearly 4,000 patients downstage, the 1-year and 5-year overall survival for LT was 94 and 74%. So basically the same 70 to 75% 5-year survival with downstaged patients as upfront Milan or UCSF patients. So that's the experience outside. And what's our protocol? We have championed a protocol for the last about 12 or 13 years, where we accept all sizes and numbers of cancers in a cirrhotic liver for transplantation, as long as there is no extrahepatic spread, as long as there is no vascular invasion, right? And then we've analyzed this series, incorporating tumor biology to predict the HCC recurrence in patients undergoing LDLT. So back in 2019-20, when we published these, we published three papers actually. On this, we had looked at data until December 2017, at which point we had done about 2,350 liver transplants, out of which 469 were selected. And we excluded those at that point in this series, patients with PVTT or portal vein tumor thrombosis. So we looked at 405 patients, and there were 50-50 within and outside of Milan, and 60-40 or 57-43 within and outside of UCSF at that time. So 475 patients, all comers, sizes, numbers wise accepted. No extrahepatic spread, no vascular invasion. So we achieved overall survivals of 5 and 10 years of 64 and 55%. Now, these would be pretty acceptable to patients who would otherwise not live beyond a median survival of around 16 to 20 months. Now, we looked at the tumor biology and we tried to classify these patients. There were three factors which were significant. One was pre-liver transplant AFP of less than 100 versus more than 100. Then whether they were within or outside of UCSF, and then whether they were FTG18 PET positive or negative. Accordingly, we distributed these patients into three risk groups: low risk group, moderate risk group, and high risk group. And high risk group had, the low risk group had none of the risk factors, and moderate risk group had 2 risk factors, and high risk group had all 3 risk factors. And obviously the recurrence rates were accordingly different. And the survivals were, again, significantly different between the low risk, medium risk, and high risk groups, right? And that is what prompted us to then reach our, so I was going to talk about downstaging, but in a minute. So you will also see that with this protocol, the low risk group, we achieved a transplant benefit of 27 months at 3 years and 42 months at 60 months. And for high risk group, this number was 17 and 25 months respectively. So even though we accepted all comers, we achieved significant transplant benefit for patients who were otherwise in other protocols thought to be too advanced for transplantation. So our downstaging protocol therefore stems from the fact that for low risk groups, there is upfront transplantation. For moderate risk groups, ideally downstage if feasible, and high risk groups should not be transplanted without downstaging, right? So that's a simple protocol based on 3 things: AFP, UCSF, and FTG18 positivity. So if you look at the BCLC schema of 2022, then you're looking at transplanting this intermediate group B patients who have multinodular disease or multifocal disease, and obviously you use extended liver transplant criteria as per the BCLC understanding, and transplant these guys. So obviously there's been an evolution of transplant eligibility as far as even the BCLC is concerned. I don't know why this has happened. Sorry about this. Can you see the lines on my screen? Can people see the lines on my screen?
Yes, sir.
Yeah,
I don't know why that has happened. I have no clue.
It's probably someone annotating, but I think you can just go ahead.
I didn't do it.
Yeah.
My cursor never moved from the middle. Anyway, I think it'll be fine. So then what has happened is that we got together in India under the aegis of INASL 3 years ago and made these guidelines. Prashant and I were a part of this, and many of you were a part of that as well. And separated the intermediate stage B into B1, B2, and B3, where this was obviously the same extended criteria and preferably downstage and then transplantation. And B2 and B3 were beyond the extended liver transplant criteria, well-defined nodules with preserved portal flow and diffuse infiltrative disease. So all of these candidates, they would eventually either have transplantation, and if liver transplantation was not available, they would go on to TACE and TER and SPRT, And these guys would directly have TARE and SBRT, but then some of these would also eventually have a transplant. So in 2020, we came out, the ILTS group, which had, again, Prashant and me and a lot of other people, we wrote a consensus guideline. And that basically suggested that selection criteria should include tumor biology in every HCC, tumor size, number, probability of survival, transplant benefit, organ availability, wait list composition, and allocation priorities. So that was one thing. So it was not a black and white rule of just size and number. And then it was said that composite criteria, which include tumor biology, are likely to replace conventional criteria, and the minimum acceptable survival for the recipient overall would be at least 60% at 5 years after living donor liver transplantation. So now let's look at the other scenario, which is the portal vein thrombosis, tumor thrombosis patients. So about 14 to 40% of HCC patients that present to us have portal vein tumor thrombosis at the time of diagnosis. So what do we do with these patients? One is to give them immunotherapy or TKIs, but then the other is to try and take those of the patients who do not have extrahepatic spread through to downstaging and transplantation, which is a protocol that we have championed again for the last 10, 11 years and published extensively on it. And finally, the world guidelines have started to include this subset of patients in their transplant criteria. So now we are talking about this set of advanced stage C patients who have portal vein invasion, right? And these would normally have systemic treatment, and their overall survival remains pretty poor. Median overall survival is just 5 to 19 months, right? And these are the groups of patients. Some of these selected group or a selected number of patients out of this group can actually be successfully taken through to transplantation after downstaging, right? Now let's talk about what portal vein tumor thrombosis means. VP0 is obviously no tumor thrombus, and VP4 is the main trunk, which is this. VP3 is the first order branch, VP2 is the second order branch, and VP1 is the third order branch, right? Or the segmental branches. So that's what tumor thrombosis classification means. And we know for a long time that stereotactic body radiation therapy is pretty effective in, in a third of patients causes complete remission of the tumor in the portal vein or the inferior vena cava. And in half the patients, it gives partial response. And that's been published again more than 10 years ago. And so does TARE, right? And this is pre-transplant PD-1 inhibitor for portal vein tumor thrombosis. So again, a lot of these patients had partial response, standard disease, and complete response. This is experience from China, from Chen's group. It's been shown in living donor liver transplantation that portal vein tumor thrombosis is not the end of the road by many living donor liver transplant centers, so basically from Korea. So these are the two papers that originally came out that showed that you can actually get significant survival, good clinical outcomes of patients with tumor thrombi in the portal veins after living donor liver transplantation, right? And then Seung-Gyu Lee's group from Asan Medical Center showed that after TACE and radiotherapy, they achieved significant overall survival in these patients with portal vein tumor thrombosis, amounting to approximately 60% at 3 years overall survival, right? So then we published our first series of patients with portal vein tumor thrombosis who were downstaged with focused radiotherapy in the form of TARE and SBRT, transarterial radioembolization, and stereotactic body radiation therapy. And then a significant proportion of these downstage patients went through to living donor liver transplantation. So this was again, patients were about 46 patients who underwent LDLT, and they had portal vein tumor thrombosis. And 25 of these were downstaged, and 21 who had VP1, 2, and 3 PVTT actually went ahead. This is the initial part of a series without downstaging. We don't do that anymore. But anyway, this was the first series that we published, or anybody published in that sense. So our protocol for downstaging these patients is that you do an assessment of the liver function, you do a triphasic CT angiography, you do a whole body FDG18 PET, and you do a bone scan. And then if they do not have any tumor thrombus in the hepatic or the portal or the IVC, and if they don't have an extrahepatic disease, any size A number is transplanted as long as it doesn't come into the high-risk group that I just talked about. And if they do, then they're downstage and transplanted. Now you look at portal vein tumor thrombosis in patients who do not have extrahepatic disease and who have child's A or B disease, then they are taken through a protocol of TARE and SPRT. And 6 to 8 weeks later, they have their first scan. And an average of around 3 months after this downstaging treatment, when two things happen. The arterial enhancement disappears in the portal vein or the hepatic vein, wherever it was earlier, and the FDG activity also disappears. When that happens, the tumor in the portal vein or the hepatic vein is deemed to have gone, and at that point we go ahead with the transplant. And if there's only partial response, then of course now we have repeat SPRT or even immunotherapy. And many of these patients have eventually gone to transplant. So this is a pre-TARE and SPRT picture. And this is, as you can see, the FDG avidity is lost in the right posterior, right portal vein tumor thrombosis, right? And this is again FDG avid HCC, and that avidity is gone after downstaging. And this was an experience that was published, and we actually achieved overall survival of 53% at 5 years, and recurrence-free survival of 52% at 5 years, right? The follow-up from these patients is that now we have 66 patients who have undergone living donor liver transplant with previous PVTT, and out of that, 45 have been downstage. In the initial series, there were 25. And this is the distribution of VP1, 2, 3, and 4. So largely VP2 and 3. And we have 15 long-term survivors, more than 3 years. 7 are more than 5 years, and 8 are between 3 and 5 years. 15 long-term survivors. So there are 9 recurrences. 17 people died, 5 post-op, 4 due to recurrence, 8 due to non-HCC causes, and 63% patients are alive without recurrence. Now, this is a group of patients where the survival with non-transplant, non-downstaging and transplant options is in a matter of months, 4 to 10 months, depending on what local therapies and systemic therapies you use. So we've, like I said, published extensively on this group of patients, and reviews and invited editorials. And now people have, we recently did another consensus on in transplant oncology as a part of LTS last year. And we have now incorporated that into the consensus guidelines, which are due to be published shortly. And now there are publications in deceased donor liver transplantation as well, where after liver transplantation has been done after successful treatment of macrovascular invasion, and this is a multi-center study, and there is another pilot study, and again from Italy, in deceased donor liver transplantation. So then a word about immunotherapy in this situation. So we have actually transplanted 5 patients who started with HCC and PVTT, and then they were downstaged with immunotherapy after other local regional treatments. So one of them had SPRT, the other had resection, TARE SPRT, and so on. And this is the immunotherapy that they had, atezo-bev usually. One of them had nivolumab. and 4 out of these 5 are living. And one of them, actually all 5 survived the transplant, but the 4th one died due to sickle cell disease 4 months later. I mean, 5th one died because of sickle cell disease 4 months later, and the other 4 are surviving. What's the world experience? This is a this is a meta-analysis which has collected 91 cases in 30 studies. It includes all cases who have been downstaged for locally advanced HCC with immunotherapy after other loco-regional treatments or ablations or even systemic treatments. So there's a mixture of patients, not necessarily portal vein tumor. This is not necessarily portal vein tumor thrombosis, but it's all a mixture of patients or locally advanced HCC. And as you can see, 10% have died, and 10% have recurred, and 26% have had rejection, but there's been an excellent outcome of patients at 2.5 years. So there's been a realignment of these patients of portal vein tumor thrombosis. They are classified into C1 and C2 in the INASL PURI recommendations, and a proportion of them will have TARE SPRT, possibly systemic therapy, and move to transplantation. So to summarize, beyond UCSF, HCC without vascular invasion and extrahepatic spread can be downstage to get 60 to 80% 5-year survival, this depending on the inclusion criteria for downstaging. And this is across DDLT and living donor transplantation. And modality of downstaging here can be TACE, TARE, SBRT, immunotherapy, or even TKIs. And all portal vein tumor thrombosis is not equal to systemic spread. Majority of it is actually locally advanced disease, and selected patients of HCC with portal vein tumor thrombosis with good liver function and non-tumor volume, good non-tumor liver volume available, usually about 70% plus, can achieve nearly 60% 5-year survival with TARE, SBRT, immunotherapy, followed by LDLT. Thank you very much.
Thank you, Dr. Swain, for that wonderful lecture. And I'm sure there'll be a lot of questions people will be interested in asking from your experience. But I think we'll keep the questions after the multidisciplinary discussion. And I'll request everyone to post the questions in the chat box. We'll address those questions towards the end. Now, I would like to invite Dr. Neeraj Saraf for his presentation.
Okay. Can you hear me, Abhideep, and see my slides?
Yes. Yes.
Okay. What happened? Can you still see them?
Yes.
Okay. Thank you. So I'd like to thank LTSI for this opportunity and starting this amazing LTSI Masterclass program. And as a part of the evolving landscape of HCC management, which we are talking of today, I'll be talking of systemic therapy in the management of HCC, and with a special emphasis on combining systemic therapy with other therapies, and so how to combine and how to sequence systemic therapy. So we've come a long way, I think, in terms of systemic therapy in the last about 7-8 years. So we all know that sorafenib was launched in 2007, and then there was a lull of about 10-11 years till lenvatinib came in 2018. And then after that, we've had atezo-bev, which was the first publication in 2020, and then we have the Himalaya trial, which was published, and now these drugs are available for use, and we're using them in our clinical practice. So there are a lot of phase 3 drugs which are available. There are a lot of phase 2 drugs under trial. So there's been a lot of progress in immunotherapy and systemic therapy by and large. And this has become a really exciting area in the management of HCC. So this is the latest BCLC, and I've put a circle in stage A, B, and C. So what I want to tell you is that systemic therapy is not, the concept has changed now, that it is not only for advanced. So I think previously, till about maybe 5 years ago, we used to think if you can't do anything else, then put them on sorafenib or lenvatinib. But the concept has changed now. So you can use them in advanced disease, you can use them in intermediate stage disease, in combination with other therapies, and even in early stage disease, it is being used along with resection. There's a trial going on of atezo-bev plus resection to see if immunotherapy can prevent recurrence. So immunotherapy is not restricted to, systemic therapy is not restricted to just advanced disease. It can be used in almost all stages of liver cancer. The other thing which I want to talk very briefly about is, especially as a hepatologist, I think liver cancer, the survival is not just about the cancer. The liver function also dictates how the liver tumor will behave, what kind of therapies you can give. So unlike other cancers, here the liver function is extremely important. And what I would just want to show is the various tools available for assessing liver function, whether it's locoregional therapy or it's systemic therapy. And the CTP score and ALB score are the ones which we commonly use. The most commonly, I think, in clinical practice being used is the CTP score. Most studies also use the CTP score, but then now there's a lot of evolving data that ALB score is probably better and fares better than the CTP score. So this is just to show the ALB grade system, which can be used across all stages and in therapeutic management of HCC. So if you look at BCLCC, ALB score correlates with overall survival and progression-free survival for all systemic therapies, whether it's TKIs or immunotherapy. So I think this is something which we need to probably start using more, and to see which patients are really fit for systemic therapy. This is just again an algorithm or a table to show the liver function reserve. So if you have a liver function reserve that is optimal, these are good patients for systemic therapy. Liver reserve 2, these are suboptimal but can be given systemic therapy. And if you are LI3 or LI4, that means advanced CTP score with poor performance. These are generally patients not really suitable for systemic therapy. So coming to the, some of the emphasis which I want to give today is on combining and sequencing. So systemic therapy can be combined with almost anything. You can, like Dr. Soin said, you can give it prior to transplant. It's used along with SBRT. It's used significantly. I think we all use it with TACE or TARE, and so in intervention radiology procedures. And there's data now coming up on its use with resection. So I think systemic therapy can be combined with all forms of treatment for HCC, and I'll show you in subsequent slides how it improves overall survival. So just to go down history a little bit, this is 2018, and this is the REFLECT trial, which was on lenvatinib, and this was actually a non-inferiority trial versus sorafenib. 954 patients total, lenvatinib versus sorafenib, and I'm not going to go into a lot of detail. We know all these studies. So the lenvatinib had a better overall survival, progression-free survival, and overall response rate as compared to sorafenib. And this really, changed the way we thought, because sorafenib, we knew, didn't have great results. There were a lot of side effects, and all of us started using lenvatinib. So lenvatinib had statistically significant better anti-tumor effect than sorafenib, although this was a non-inferiority study. Then there were a lot of papers on lenvatinib, and this is a recent real-world study, which is called the Elevator study, 205 patients, 14 centers. This was published a couple of years ago in liver cancer. And this confirmed the efficacy of lenvatinib, and it supported the use of lenvatinib as a meaningful alternative for patients that cannot be treated with IO-based combinations in first-line HCC. So this paper was published in 22, and by this time, immunotherapy had become first line. But this real-world study showed that lenvatinib was probably almost as good as immunotherapy and could be used in patients in whom immunotherapy could not be used. Now let's see what we can combine lenvatinib with. So there's a lot of data on lenvatinib and TACE, and these are all intermediate stage patients most of the times. So in the sorafenib days, there were many studies, the SPACE trial and the TACE-2 trials, the STAR trial, and all of these showed that combining TACE with sorafenib did not help or did not improve the survival or overall survival or the progression-free survival. So there was no benefit in the sorafenib days. But this has changed now when we talk of lenvatinib. So this is just to show that if you give lenvatinib prior to, so this is if you give lenvatinib prior to TACE, there is increased. So after giving lenvatinib, the abnormal tumor vasculature becomes normal, and this causes decreased tumor interstitial pressure, decreased vascular permeability, and improves the drug delivery of the TACE. So this concept came in that you can give lenvatinib first, and that improves the drug delivery of TACE. So this is something different than what we usually do in clinical practice, that we do TACE first and then give lenvatinib subsequently. So this was the proof of concept study by Kudo, in which they gave lenvatinib followed by TACE, and the overall survival and the median progression-free survival was significantly better in the lenvatinib plus TACE group as compared to the TACE group. So this is the first time that this concept was given, that you can first give lenvatinib, make the liver functions better, or maybe even convert the TACE ineligible patients to TACE eligible patients and then to TACE in them. So this is the TACTICS-L study, which was the TACE in combination with lenvatinib in patients with unresectable HCC. And in this was a single-arm phase 2 study in which they used lenvatinib first, which was started 2 weeks prior to TACE, and it was stopped for 2 days prior to TACE and then subsequently continued again. And the median progression-free survival was 28 months, and a median overall survival was not reached. So again, a study showing that len plus TACE is a better combination, is a good combination, and gives better results than TACE alone. Then there is the launch trial, again showing similar results. So there were two groups, the lenvatinib group versus the lenvatinib plus TACE group. And you can see in both the graphs that the overall survival at 12 months and 24 months, the progression-free survival was better in the len plus TACE group as compared to the len group alone. So again, a study showing that in patients with intermediate stage HCC, a combination of TKIs plus local regional therapy can give better results than TKIs alone, and also TACE alone, which this study showed. So this study had 120 unresectable HCC patients. So TACE plus lenvatinib was given to 60 patients and TACE alone to 60. So the previous studies were TACE plus lenvatinib versus lenvatinib. This is TACE plus lenvatinib versus TACE. And if you look here, the 1-year survival and the 2-year survival are significantly better than in the combination group as compared to the TACE alone. And this is again a graphical representation. The red line is the TACE plus lenvatinib, the blue is TACE alone. So there is a significantly better survival overall, as well as progression-free survival of TACE plus lenvatinib as compared to TACE alone. So this is a comparison amongst major lenvatinib trials. And so the REFLECT had an overall survival of 13.6 months. But some other studies like the LAUNCH have a significantly better survival when you combine it with when you combine local regional therapy with lenvatinib. Now, the question comes, should you give lenvatinib with every patient of TACE? Probably not. So what all these studies conclude is that if you have significant tumor burden, such as those who had some PVTT, if they had a high AFP of more than 400, 3 or more intrahepatic tumors, or the primary tumor size of more than 5 centimeters, then probably these are good patients to combine loco-regional therapy with lenvatinib. You could give lenvatinib before TACE, or you could use it after TACE, as shown by these studies. So that's lenvatinib, which we've been using for the last 6-7 years now. Now there's a paradigm shift in cancer therapy in HCC. So earlier we were targeting the tumor cells, and now we are targeting the immune cells, which in place target the tumor cells. So there's a paradigm shift of using targeting the immune cells. Now, this is I'm not going to go into too much detail. This is a busy slide, mechanistic insights of the available therapeutic agents. And I want to focus, if you can see from my cursor, mainly on the immune checkpoint inhibition, which causes increased T cell activation. So you have anti-PD-1 antibodies, anti-CTLA-4 antibodies. These activate CD8 T cells. They increased the phagocytic activity of TAMs, and they have been used, and I'll show in subsequent studies in managing HCC, the immune checkpoint inhibitors. Another concept which is there, and I'll talk about it a little later, is the cold versus the hot tumor. So HCC is generally considered to be a cold tumor. So if you can convert this cold tumor by procedures like a TACE or the RFA or the SBRT, then by activating T cells, these become hot tumor and are more responsive to drugs like atezo-bev or trema and dorvi. So again, I'm not going to go into details of this study. We all know this is the IM-Brave 150 phase 3 trial that brought atezo-bev into picture in unresectable HCC. Again, it was compared to sorafenib. At that time, that was the only drug available for comparison when this study started. And the atezo-bev group had a significantly better overall survival as compared to sorafenib, a 19.2 versus 13.4 months. And after this trial, atezo-bev became the first-line therapy in advanced HCC in the BCLC staging. And atezo-bev did group well in all subgroups, in the viral as well as the non-viral, although there is some controversy in the non-viral group, and there is some data showing that probably immunotherapy doesn't work as well in the non-viral group as compared to the viral group. So that was the registration trial. There is more real-world data also. This is the AB Real observational registry of atezo-bev in routine clinical practice. And again, so the blue line is the real-world data. The red is the registration trial. And you can see that they're both almost similar. So the real-world data was very similar to the IM-Brave study, showing similar survivals. So atezo-bev has now established a place in managing advanced HCC and as a first-line treatment in unresectable HCC. We published, this is a couple of years ago, data of about 34 patients. I think now we have more than 50 patients. The median overall survival was 8 months. The overall response rate and survival at 12, 24, and 48 weeks was 46%, 30%, and 30%. That was for overall response rate, and survival was 84, 84, and 30 at 4 weeks, 48 weeks. So we have now about 55 patients of atezo-bev, and I think we'll probably come out with more data on that. There is some data from AIG as well, again showing good results, and they have even shown that they have used it in some late child's B patients, although we've used it in mostly early child's B or child's A patient. Now, this is a study which real world study again comparing atezo-bev versus lenvatinib. Now, I think this is what is the need of the hour. You can't keep comparing everything to sorafenib, which is an obsolete drug, and show better results. So this is a large study by Gardinini from Italy. 1,341 patients who received lenvatinib, 864 patients who received atezo-bev, and AB did not show a survival advantage over lenvatinib. Overall survival was prolonged by atezo-bev over lenvatinib marginally in the viral patients, but conversely, overall survival was prolonged by lenvatinib in patients with MASLD. So there was no meaningful difference in overall survival between atezo-bev and lenvatinib, and it showed some signs that it may be actually better. That means lenvatinib may be actually better than atezo-bev in non-viral. And I think we will all agree that all the tumors we see now, most of them at least, are in non-viral disease. Hep C is we've almost eradicated Hep C. Hep B also, I think the HCC, what we are seeing is much less because of very good antivirals available. In the future, we're going to see more and more of MASLD. And this is a very important study that probably lenvatinib is equally good in treating MASLD-related HCC as compared to atezo-bev. And we all know the price difference and the ease of giving lenvatinib. But I think more data is needed before we can really say which one is better. So that was about atezo-bev. Then there was this concept of revisiting anti-CTLA-4 and anti-PD-L1 combination strategy. These combinations were already being used. So, a single dose of tremelimumab with durvalumab was already being used in lung cancers. It was being used in melanomas. So this study, it was thought that a single priming dose of tremelimumab with durva could it improve immune-mediated clinical activity in HCC patients while minimizing toxicity. So this was the Himalaya trial. Again, we know about this trial, recently published in the Lancet, and India was also part of this. Mostly oncology groups took part. 190 trial sites, 1,324 patients. So this study compared one shot of tremi with durva versus durva alone versus sorafenib alone. Again, what I don't like about this study, and which again, because these studies started when only sorafenib was available. So what is different in this study versus atezo-bev is that this is the longest study showing of 5 years, and this is the longest data on immunotherapy. So a 60-month overall survival of 19.6% with the STRIDE combination. That means tremi and durva versus 9.4 in the sorafenib group. So this is a newer drug. It's available in India. I personally don't have a lot of experience yet. Hepatologists are not yet approved to use it. So it's only being used by oncologists right now. But I think because we have a precedence with atezo-bev, hopefully we will get prescribing rights for the STRIDE combination as well very soon. So STRIDE again showed that it improved survival in all groups like atezo-bev. A little bit, because all of us are interested in transplant. Dr. Soin has spoken a little about this. So immunotherapy and transplant for HCC. So this is the Vitality study published by Trevisan from Mount Sinai last year in Journal of Hepatology. This was an intention to treat analysis. So there were 31 patients within Milan, 86 patients beyond Milan, and 65 could be downstaged to a transplant. Now, remember, these are mostly DDLTs, so they could be downstaged with using immunotherapy. But what I want to highlight is, because I want to emphasize on combination therapy. So in this study, 94% patients received from some form of locoregional therapy along with immunotherapy. So again, immunotherapy along with locoregional therapy could be very useful in downstaging patients to transplant, as shown in this study. The 1-year intention to treat survival was 94.6%, 2 years 81%, 3 years 71%. So now the fear of using immunotherapy prior to transplant is that patients will reject. So obviously you need to give them a cooling off period. In this study, only 7 patients had rejection, and only 1 of these patients had a graft loss because of rejection. So what this study showed was that even the rejection rates were not very high. They were to the tune of 20%, and the rejections were not so bad that you would actually lose a graft. So I think this, if you give them a cooling period, then this the thought of not using immunotherapy prior to transplant is really not justified. Rejection is really not a big issue. Again, Dr. Soin showed this. We presented this at the ILTS last year. So we have 8 patients now who we have given immunotherapy prior to transplant, and none of them have actually had rejection after transplant. And again, what I want to highlight is the combination part. So all of these have been given in combination with a locoregional therapy, whether it was TARE or TACE or with SBRT. So again, our data is similar, that you can use it in combination with SBRT or TARE, and give it prior to transplant for downstaging. Now, this is a review article recently published in the Journal of Hepatology. Again, talking of using immunotherapy prior to transplant. It is a little busy slide. I'm not going to go through all of it. What I just want to highlight is the washout. So if you wait too long, then the problem is that the HCC could progress. If you wait too short a period, then there are higher chances of rejection. And based on a lot of multiple studies, this review article recommended that about a 4 weeks washout period is probably good enough to really prevent significant rejection after transplant. So this is ICI therapy pre-transplant, rejection rate of about 30%, rejection-related mortality rate of about 6%. And if you compare it with no ICI therapy prior to transplant, the rejection rates were 10 to 30%. So they're a bit lower, but then I don't think you're really losing graft because of using immunotherapy prior to transplant. Again, Dr. Soin showed this, 91 HCC cases, 30 studies. And again, what I want to highlight is that this study actually showed that ICI washout period of 94 days or more correlated with less than 20% allograft rejection, and it equaled, patients' normal rejection rate in which you don't use immunotherapy. So 3 months, again, I personally feel is a long time. I think most centers now and a lot of studies have shown that probably about 6 weeks is a good washout period after using immunotherapy in going to transplant. Quickly, I'll just go over some combinations of immunotherapy. So you can use 2 systemic therapies, lenvatinib plus immunotherapy. So this is again a study published in Liver Cancer, 1325 patients. And so they used lenvatinib with various other systemic therapies. And if you look at lenvatinib and immunotherapy, they had the best overall survival of 47 months. So I think len plus immunotherapy again is a good combination. This was called the relevant study, and I think there's a lot of potential for using lenvatinib and immunotherapy. Similarly, you could use atezo-bev or immunotherapy along with local regional therapy like TARE or TACE. And again, there's a lot of studies going on this, the LEAP trial, the CheckMate trial, and the recently published Emerald-1. And I'll just talk of that very briefly, which was Durva plus bevacizumab plus TACE versus TACE alone. So this is again a study using TARE plus immunotherapy. So again, my emphasis on combination, 1522 patients of immunotherapy alone versus 142 with TARE and immunotherapy. And you can see that the survival of the combo of TARE and immunotherapy was significantly better than TARE alone. Now, this is the Emerald study. I think this is really has gives a lot of promise of using local regional therapy with immunotherapy. So this was Durva plus bevacizumab plus TACE versus there were two groups, Durva plus TACE versus and placebo plus TACE, and the safety profile was significant, and the median progression-free survival was significantly better in the immunotherapy plus TACE group as compared to the TACE group alone. So I think the Emerald study again tells us that using immunotherapy along with TACE can improve results significantly as compared to using immunotherapy or TACE alone. SBRT also can be used with immunotherapy. We haven't published it yet, but we have some experience. And again, SBRT is something, so when we talk of sequencing, if you use SBRT prior to immunotherapy for the portal vein tumor thrombus, you actually convert a so-called cold tumor into a hot tumor, and you can make the results of immunotherapy better. So SBRT plus immunotherapy, I think, is again a great combination for downstaging patients and for using in combining and sequencing. So this is just to show various combinations, and I think sequencing is important, especially when you talk of the concept of a cold and hot tumor. So we've talked of lenvatinib and TACE sequencing either way, and then again TARE plus immunotherapy and SBRT plus immunotherapy, where the combining and sequencing is important. So just last slide. This is what we usually do. So if it's a resectable or a transplantable patient without downstaging, we obviously do resection or transplant. So they go for surgery. If they're not resectable or transplantable, then if the patients are advanced child score and poor performance status or extrahepatic disease, then they go for best supportive care. But if they have child's A or early child's B, good performance, they're eligible for ICI, then we use atezo-bev if they don't have large varices. If they have large varices or bevacizumab is not indicated, then we have started using the STRIDE combination. And if they progress on that, then we use lenvatinib, and some of them we have used cabozantinib as well. In patients, this is again, Dr. Soin talked about this. In child's A patient, good performance, no extrahepatic disease. We have used TACE, TARE plus SBRT, and in some patients, we've used systemic therapy in form of atezo-bev to downstage them for the liver transplantation. So my take-home message is that systemic therapy is here to stay. You can use it in all stages of the BCLC. I think combining is going to be the future with local regional therapy, with SBRT, with other immune checkpoint inhibitors, with other TKIs, and our ultimate aim will be to try and get these patients to transplant. So especially immunotherapy and systemic therapy can be combined with ICIs, with TKIs, with local regional therapy, and with resection, and maybe in a lot of patients with transplant as well. And these are just to show that, a lot of trials are going on combining systemic therapy with local regional therapy, and showing good results. Thank you.
Thank you, Dr. Neeraj, for that enlightening and a very practical talk. I think we move on to the panel discussion, which Prashant is going to organize. Prashant, there are a few questions in the chat box. If you can address that, a couple of questions to be addressed to Dr. Soin. If you can address that during that panel discussion, that would be great.
Okay, we'll try to, I think we'll try to see whether we cover it in the panel discussion. Else, I think we'll take the questions at the end, if that's okay. We will start. Can you see my screen?
Yes.
Okay. So I think we've had two excellent talks on how management of HCC has evolved over the years in terms of expanding criteria, as well as the emerging role of systemic therapy in improving outcomes. Since this is a masterclass and the aim was also to cater to youngsters, to those starting off their careers in hepatology, liver surgery, as well as in oncology, I hope we have oncologists joining us here, because I think we are moving on to getting together with oncologists as well in treating these patients of HCC. We thought that we should also include this panel discussion as to how management of HCC has now become a multidisciplinary team effort rather than just the domain of a surgeon or a hepatologist. The aim being to cater to every single stage of HCC and every patient suffering from it, and also to improve outcomes. So what we are going to address in this panel discussion is what is now considered to be standard of care in every aspect of HCC management. Number two, what are the guidelines in managing patients with HCC at different time points? And the aim was to include people who are actually involved in managing these patients, because it's not only us who are managing them now. And so if you see this panel, you will see that we have Dr. Bajal, our intervention radiologist. I think he needs no introduction. Dr. Tarun is our diagnostic radiology. Dr. Ankur and Kamar are surgeons. Dr. Shyam Bisht is our radiation oncologist. Dr. Narendra is a hepatologist. And Dr. Dheeraj, who is a pathologist with us. So let's start off, and a little bit of epidemiology to start with, to tell you why HCC is so important today. So it is the 6th most common primary liver cancer in adults. It's the 6th most common cancer worldwide, and liver cancer is now the 3rd leading cause of cancer death. We will also see that if you look at both the male as well as the female, in the males, it's the 5th most common cancer worldwide, and liver cancer is the 2nd leading cause of cancer death in men now. In women, it's the 9th most common cancer, and it's the 5th leading cause of cancer death. If you look at the worldwide figures, it was expected that about 7 million people would die of HCC in the year 2022, and this comes from this worldwide data. Now, there are deaths because of 2 reasons in HCC patients. One is because they develop advanced metastatic disease, and second is because HCCs typically occur in cirrhotic livers, and therefore patients go on to decompensation, and when they decompensate, they can die of liver disease itself. We are often known, or we know this for a long time, that the most common cause of the underlying liver disease used to be HCV and HBV, but now HCC on NAFLD and NASH is posing, what is MASH now or MAFLD now, is posing a very difficult group of patients to deal with. We also know that HCC is a very wide spectrum. So it ranges from a single lesion, early HCC, to up to 3 tumors, none more than 3 centimeters in size, which are basically what again you would put under the BCLC as early tumors and within conventional criteria for transplant or dissection. The multifocal HCC, the large HCCs with vascular involvement, and ultimately those with extrahepatic disease. So let's start off with the first point, and that's on surveillance of patients for HCC. Who and how should be undergoing surveillance? And we have Dr. Narendra to tell us about this. Narendra, if you could unmute and opine on these particular aspects.
Yes, sir. Good evening, all. So we often detect HCCs at advanced stage, not at early stage. We at transplant center, gastroenterology, hepatology, we know that these patients should have surveillance. But at primary care physician level, where most of these patients are managed initially, this surveillance part is missed. So it is recommended for any cirrhosis, irrespective of etiology, for child A and child B, because incidence is more than 1% per year. Child C patients will have poor life expectancy, and surveillance is recommended in child C only if they are in future liver transplant candidates. For patients with hepatitis B without cirrhosis, incidence is 0.2% per year, and it is recommended for males more than 40 years, females more than 50 years, or at earlier stage for Africans if there is family history of HCC or PSB score is 10 or more. In all these, surveillance is recommended. Patients with hepatitis C non-cirrhotic successfully treated, and at present for NAFLD, it is not cost-effective and not recommended. How modalities for surveillance? It is ultrasound and alpha-fetoprotein at present. Sensitivity is 61%, specificity is 92%. AFP-L3 is not available here. DCP recent data is emerging. Multi-target algorithm is DNA methylation products in blood. GALAD is gender, age, AFP, L3, EFP, and DCP. It is not based on imaging. And this Doyle sound, it is not validated, but it increases sensitivity of alpha-fetoprotein by 2 to 10%. Ultrasound 6 monthly is currently accepted, but what are issues with ultrasound? So in upper left corner, in between these two arrows, we see HCC, but this is barely visible. We know because it is marked by arrows. So largely isoechoic HCCs are missed. In second figure, we can see a shadow of two ribs. So small HCC will be missed in this. In third figure, again, if we see carefully, we will detect it. Then lower left figure, ultrasound and fatty liver. So this arrow shows ill-defined HCC. It was picked in retrospect when CT showed A, MRI showed a HCC. That is in next figure. ASLD has suggested that we use ultrasound visualization score. A shows cardiac cirrhosis because hepatic veins are dilated, entire liver is visible. So it is visualization score A, that is no limitations in visualization. Score B, that is middle figure. It shows it is not very clearly visible liver, but still we can make impression. C shows visualization category C. We cannot see anything due to impact of steatosis. Next, sir. So if what is place of CT or MRI if ultrasound shows more than 1 centimeter lesion, or alpha-fetoprotein is 20 or more, or alpha-fetoprotein is increasing, or visualization score is 3, then we cannot rely on ultrasound and we should get CT or MRI. If visualization score is B or less than 1 centimeter lesion in ultrasound, then we repeat ultrasound 3 to 6 months, not at 6 months. And ultrasound visualization score, it should be assessed and reported in every ultrasound report in cirrhosis. For non-cirrhotic NASH, at present, we don't know which patients are at higher risk. HCC incidence is very low. It is 0.008 per 100% year. So at present, ultrasound-based surveillance is not recommended in these persons. And we can decide on case-to-case basis.
So thank you, Naren, for that. And this is just a summary slide to tell you that if you were to do ultrasound and alpha-fetoprotein for a period every 6 months, these are the results that you would get. And if you have a patient who is at a high risk, we need to detect early tumors that are potentially amenable to curative treatment. And many of you must have heard that there is a newer modality that is being spoken about, and that is abbreviated MRI. Now, since this is something new, I would like Dr. Tarun, who's our diagnostic radiologist, to let us know about what exactly we are looking for in abbreviated MRI and what is the current evidence for the same in terms of a screening modality. Dr. Tarun?
Yeah, good evening, everyone. So this is the current interest of the radiology community is into abbreviated MRI for HCC surveillance. So based upon this Korean article, we have seen that the meta-analysis of 15 studies and at least 4,400 patients showed that the ultrasound sensitivity for early stage HCC is only 47%. So, and the recent studies in surveillance settings, the sensitivity turned out to be less than 30%. Now, CT, we all know, has some inherent drawbacks in the form of radiation hazards and the risk of using iodine, which can cause allergy reactions. And complete MRI, we all know, for characterizing focal hepatic lesions has superb performance. But MRI as a surveillance tool has some limitations, high costs, and extended times, and the interpretation of results. So this led to the radiology community coming to this abbreviated MRI. So what the community is currently working at, three kind of approaches. One, using sequences which are hepatobiliary excretion. The second approach is using a dynamic contrast enhanced MRI. And the third approach is using sequences which are non-contrast or non-enhancing. So using these sequences, currently the communities are working on abbreviated MRI sequences. But I would like to highlight here that the technique hasn't yet become very robust and the results are equivocal. One thing is for sure, when you detect a lesion, you do a complete MRI, detect a lesion, characterize it, and when you need to follow it, then you can do it with an abbreviated MRI. But as of now, we are not using these sequences alone, either of these approaches alone for the surveillance. Now the research is going on. Let's see where we land up.
Thanks, Tarun. So we'll continue with you. And since we've done the surveillance part now, and how would you do a surveillance in patients who are considered to be at risk or not at very high risk? Let's go on to the next part, which is on diagnosis. And let's start out with imaging for the diagnosis of HCC.
Thanks, Prashant. So the imaging basis of detecting HCC, we all know is the LIRADS criteria. There are major features in the LIRADS criteria. 5 of them I would like to highlight. One is the arterial phase hyperenhancement, which is non-peripheral. And then second is the washout, again non-peripheral, in the central part of the lesion. Third is the capsule, which enhances later on the delayed phase, and it's only towards the periphery. Then we also look at the size and the threshold growth, which should be increase in size of at least 50% in a span of 6 months. So based upon these criteria, next slide, Prashant. So we try to characterize the lesion into LR1, 2, 3, 4, and 5. So LR1 are definitely benign, LR2 are probably benign, and then we have LR3 intermediate, very likely malignant, LR4, and obviously malignant LR5 lesions. So when we use the LIRADS criteria, we first determine whether there is enhancement. Then we try to look at the type of enhancement, whether it's a non-rim enhancement, which is more suspicious than the hypo or iso enhancement. Then we look at the size of the lesion, and we look at the additional typical features of HCC, like the enhancing capsule, the non-peripheral washout, and growth of the lesion. There are certain additional categories like LRTIV, tumor in vein, LRM, malignant but not HCC, LRTR, treated HCC, and LRNC, which is non-characterizable for lesions because of the technical quality of imaging. So the most interesting part of this table is when we have to decide if the lesion is to be placed in category LR3, which is intermediate probability, or LR4, which is probable HCC, or in category LR5, which is definitely HCC. So as we have seen, we have to first determine the enhancement and whether it is non-rim arterial phase hyperenhancement. Then we look at the size of the observation and finally count the number of additional major features. And based upon these, the patterns that we see, we divide them into LR3, LR4, and LR5. Next. So we all know when to use LRI, but I would like to, I'm using this slide to just to highlight where we do not use LIRADS. So we use LIRADS in cirrhosis and Hep B virus infection, and when we know there is an HCC or there was a prior HCC. But we do not use LIRADS if the patient is less than 18 years of age, cirrhosis due to congenital hepatic fibrosis, or cirrhosis caused by vascular disorders like Budd-Chiari or portal vein occlusion, diffuse nodular regenerative hyperplasia, or because of cardiac congestion, cardiac cirrhosis patients. Next. So this slide shows us, this is a multi-phase CT scan. Looking at the first image on the left, on the top, we see the plane scan where the lesion is hypodense. And then we, on the arterial phase, the second image, we see that the lesion shows us enhancement, which is non-peripheral. It's in the central part of the lesion mostly. The third image shows you, this is the late arterial phase where the heterogeneous enhancement becomes homogeneous. And then on the right, the topmost image shows you the portal venous phase where the enhancing areas now start turning hypodense. Mark you the areas which enhanced first are showing you washout first. Moving on to the middle image on the right side, you see now that the entire lesion starts showing you washout. And then the last delayed phase, you see a very nice capsular enhancement. So this is the LIRADS category LR5 lesion detected on CT angio. Next. So on MRI, we use the dynamic phase imaging. Similarly, we use the pre-contrast T1 weighted sequence, the arterial portal venous delayed phase. And we also use the hepatobiliary imaging using hepatobiliary excretin contrast, which shows us the HCC would show us washout on this after 15 to 20 minutes of contrast administration. Additional sequences like T2 weighted, diffusion weighted, and in and out of phase imaging are also used. Next slide. So I'll not waste much time on this, but this is on the dynamic MR. You can see on the plane T1 sequence, the image on the right, top row, shows you the lesion, which is slightly hyperintense. And in the bottom row, you see typical enhancement and then washout. And on the hepatobiliary phase, there is the lesion shows no uptake of MR contrast there. Next. Now, there are other imaging modalities which play a role in the diagnosis as well as in the treatment part of HCC. Important modality being the contrast-enhanced ultrasound, which is being selectively used in our center in some cases. And the role of contrast-enhanced ultrasound is evolving. So initially, it's been used in diagnosis. The contrast injected, the ultrasound contrast which is injected shows us the similar dynamic enhancement characteristics of early enhancement and then washout. It's used for the diagnosis and characterization of HCC to confirm the portal vein thrombosis, especially in the smaller peripheral venous branches. And it's used in intraoperative, can be used to increase the detection of smaller lesions. And the most important role which is emerging now is the ultrasound evaluation of HCC response to chemoembolization. So because the contrast-enhanced ultrasound is not limited because of the lipiodol deposition, the typical enhancement and washout starts coming only after day 1 of the treatment given to the tumor. That means that you can use contrast-enhanced ultrasound to look at the kill and to look at any residual lesions starting from day 1, because the lipiodol plays no role in it, and also because of the immunotherapy response, it does not hamper. Now, alternative to contrast-enhanced MRI and contrast-enhanced CT is the evaluation of LRT is efficacies as early as day 1, and it has a very high sensitivity with contrast-enhanced MRI or contrast-enhanced CT. It's unaffected by lipiodol retention, as I told you, or by the inflammatory infiltrate, which obscures the differentiation from residual tumor after treatment. Has a very high spatial and temporal resolution. However, the catch is that it's operator dependent. So the ultrasonologist has to be very skilled and using this technique. So with the learning care curve, I think at all centers, the ultrasonologists can very well differentiate between the non-tumor and tumor areas.
Okay, thank
So
you.
this
Thank you very
has
much, Tarun.
yeah.
I think, yeah. The last point that you wanted to make probably was that it's very
It's
advantageous in detection of residual disease.
yeah.
And combining it with MRI would basically help in following up these patients. So
Yeah.
from imaging, and thank you, Tarun, that was very, very clear. And I think it was a great learning for everyone who's here. Even us, we are not very sure even now of where these modalities are most useful and where they can be used best. From imaging, now let's go to tumor markers and the role of biopsy. And Dr. Ankur, I would request you to please take us through this.
Yeah, hi. Good evening, everyone. Hope you can hear me.
Yes, we can. Please go ahead. Yeah.
So now, as far as biomarkers are concerned in the diagnosis of HCC, so there would be two categories of biomarkers that we look at. Serological biomarkers, the traditional ones like AFP that Dr. Naren discussed in detail, is used for surveillance with ultrasound. And its isoform like AFP L3 fraction and PIVCA. The other category would be, the tumor elements that we can detect in blood, which would be, it would be called liquid biopsy in all. Now, as far as the diagnostic aspect of these tumor markers is concerned, all of them, all of them which have, which we know don't have great sensitivity. And there are newer tests that are newer markers that are being developed, but they have to clear phase 3 and phase 4 trials and approvals. So as of now, at this point, AS societies, especially AASLD, advises against use of biomarkers, including liquid biopsy, to make a diagnosis of HCC given the insufficient evidence. There is, however, I was in the previous slide, there was, you could use a combination of the 3 tumor markers mentioned at the top in this Gallet score. There is a phase 3 trial that has been done, and it's proven that it's like 60 to 80% sensitive, but still the phase 4 is pending, and we'll see how this turns out. Now let's come to how the tumor markers are used in HCC. Right now, the prime importance of using tumor markers is in the prognostication of the tumors. So higher levels of these tumors, AFP and in PIVCA2 and AFP L3, can help prognosticate the the patient. The higher levels, give you predict a poorer prognosis and an increased risk of recurrence. So on the right are the INASL guidelines that we had discussed earlier, the PURI 3 recommendations, and so again they are in the line with this, that diagnosis probably not at this point, but yes, for prognostication, for prediction of risk of recurrence, and also many programs take AFP more than 1,000 as a exclusion criteria for LT. Although with treatment, if AFP decreases, patients can be taken up for LT, but that limit, the cutoff of that decrease, is not yet decided. Also, they help us in monitoring the response to therapy. Now, as far as biopsy is concerned, so the interest in biopsy to diagnose HCC, it has been kind of, at one point it went down, then it came up again. That's because imaging is well advanced, and this non-invasive form of diagnosis is obviously very acceptable. But nowadays, with the advent of molecular analysis and immunotherapy and molecular therapy being developed, there is a resurgence in interest even for tumors that are already we know that they are HCC. So traditionally, in LIRADS classification, if patients don't are not fitting into LIRADS, for example, patients who don't have cirrhosis, or the patients who don't have HBV, or the cirrhosis of vascular etiology, they do not qualify for LIRAD, so they would probably invite a biopsy to confirm the diagnosis. And in the LIRADs category, if they are LR4, which means they're probably malignant, but not sure. So they can either go for either repeat imaging after some time, or if an immediate diagnosis is required, they can go for biopsy. Also, AASLD is now recommending biopsy in MDT discussion for, again, molecular analysis. Similarly, for LR5, where we know that this is a malignant tumor, AASLD now recommends that for a molecular analysis, biopsy can be done, a decision can be taken in a multidisciplinary team meeting. For LRM, that means that that can be a mixed tumor, that can be a non-HCC malignant tumor. Yes, biopsy is required. So those are grossly the main indications for diagnosis.
Thank you, Dr. Ankur. And I think you also alluded to this, and this is just some data which shows you that if you have alpha fetoprotein alone, you would have a sensitivity of somewhere around 58%, which increases to around 72.8% if you combine it with PIVKA, and the specificity also increases if you were to combine the two. So this is, I think, something that we have started following, and I would like to tell you that over the last 5 years or so, routinely now, it's not only alpha fetoprotein, but every patient of HCC undergoes PIVKA2 test as well, because we know very clearly that only 60% of them would be actually alpha fetoprotein secretors, and the rest of the 40 generally are going to be your PIVKA secretors. And therefore, if you do a combination of both, you're not going to miss most of these, or it also is going to help you in prognostication of these patients. I'll go to our pathologist now, and Dr. Dheeraj, I would like to know from you, and everyone would like to know from you, when you report a biopsy, is there a particular protocol or a particular format that you follow so that you do not miss something that is important either in the diagnosis or in the prognostication of these patients?
Yeah. Can you hear me?
Yes, please.
Okay. Thank you, Prashant, and good evening, everybody. So we receive biopsy in two forms, basically. One is the true cut biopsy, which is for the primary diagnosis, and second, we receive the explant liver. So I will brief on the true cut biopsy, which is very short. Like Ankur told, there's a molecular marker, you have to do prognostic marker. So tissue is an issue, and the judicious use of the tissue is very important. So first, we have to see whether this is a benign or malignant lesion. If it is a malignant, then in true cut biopsy, whether it is primary or it is a metastatic from some other side, then to prove this, we have to do immunohistochemistry and some prognostic markers. So next slide, please. In explant biopsy, we follow the CAP protocol. It is College of American Pathologists, and it's a sign up reporting. So in the report, we mention what is the procedure done, whether it is lobectomy or a half or full liver is there. Histopathologic type, whether it is hepatocellular carcinoma or this is mixed cholangiocarcinoma or whatever it is there. Then histological grade is a 4 type, well differentiated, moderately, poorly, and undifferentiated. Then we have to mention tumor focality, whether it is one tumor or multiple tumors. Tumor characteristic, what is the stomach gastroplasia, what is the fibrosis and everything. And most important is we have to see the extent of tumor necrosis, especially after the TACE or tear. Then we have to mention it is cirrhosis, vascular invasion, whether it is minor or major. Then we have to mention the perineural invasion is there or not. What is the state of the margin, whether it is the hilar margin or it is a free margin. Then what are the, usually we don't find lymph node in the explant liver, but if it is there, then we have to mention the regional lymph node status also, pathological staging, and any additional comment like the etiology, whether it is hepatitis B, C, NASH, or anything else. Next slide, please. So grading of HCC must be included in the reporting. That is for scale classification. I have already mentioned, and then I have already mentioned whether it is the type and everything.
So I'd also like Dr. Dheeraj for you to comment on the role and the current status of liquid biopsy, because we keep hearing about this, and Dr. Ankur also mentioned about it. So what's the current status, and what do you look for, and what do you think is going to be the future of liquid biopsy as far as HCC is concerned?
Okay. So we are currently doing liquid biopsies, but liquid biopsy, first of all, it is not a diagnostic for any cancer. Okay, it is basically for the treatment response monitoring and prognostic. You cannot diagnose only on the basis of liquid biopsy. So first thing, and it's early detection remains a challenge. And liquid biopsy offer a non-invasive, real-time molecular profiling tool. So unlike hepatocellular carcinoma, the liquid biopsy is more popular in lung carcinoma or colon carcinoma because we can target the mutant there. But in hepatocellular carcinoma, we are still developing. So what we do in liquid biopsy, we have to analyze of tumor derivative component, especially the three, that is circulating tumor DNA, that is ctDNA, other is circulating tumor cells, and third is exome, which we extract the microRNA. The advantage are it is minimally invasive. You can repeat it at a frequent time. It's a real-time monitoring of tumor dynamics, and it detects the molecular alteration even before the radiological evidence. Next slide, please. So, what is the current applications are? Usually, you have to see in a primary tumor, you have to take out the what is the mutation causing the carcinoma. It is HCC, whether it is lung carcinoma or any other carcinoma. And then with the blood, with the liquid biopsy, you see the component of these mutants. Like detection in HCC are TP53 and TERT promoters. Then methylation markers are SEPT9 and RAS-F1A. Research showing promising in identifying early HCC. Okay. So this is for the early diagnosis. Now for the prognostication, while the more is the ctDNA, it is associated with the poor prognosis. I mean, mutation burden is also the tumor mutation burden. We have to see the how many mutants are there in per picogram of the blood. And it often is linked to the tumor aggressiveness. So therapeutic monitor is the main use of the liquid biopsy. It detect the dynamic change in ctDNA, reflect the treatment response or relapse. So the limitations, the challenges are, if the ctDNA is very low, then it is really difficult to pick, to diagnose the early stage HCC. Well, it's a technical variability, and though we are doing it, but all other centers, there are lack of standardization. The future is, if we can mix with ctDNA, with mRNA, and proteomics. So all three omics should, give the complete diagnosis. But integration into the routine surveillance for the high-risk population. There's another trials is going on, which is due for the validation, that is NCT 0518006.
Okay, thank you, Dr. Dheeraj. So now we've done the surveillance, we've done the diagnosis, imaging as well as tissue, as well as in terms of tumor markers and everything. And now we come to the actual part that we are managing an HCC patient. And I think that there are two parts in this particular management. One has to do with staging, and number two has to do with prognostication. So Dr. Ankur, of course, our previous speakers have already spoken about the staging. So if you could quickly run through the staging systems that are there in HCC, what are the ones that we are currently using, and what are the advantages or the key points of the same?
Yeah, thank you, Dr. Prashant. So since 1971, we know that, when it comes to HCC, it's not just the tumor extent, like we use TNM classification, just the tumor extent. It's not just the tumor extent, but the degree of hepatic dysfunction that affects the prognosis. So there have been attempts to include that since 1971, and multiple scoring systems have been, multiple staging systems have been introduced since then. You can see the timeline up there. But since 1999, when this BCLC system was first introduced, it caught an eye, it got popular. It has had multiple, updations, as more evidence becomes available about the treatment, prognosis, and so on. And whatever the staging systems are available, they have elements of tumor factors, including AFP, liver factors, and the performance status. So all of them obviously contribute to how you can stage a HCC patient. Next, please. So now this is the most modern version of BCLC, the 2022 thing. So at the top you can see there is disease extent. Based on disease extent, then your performance score, that is the ECOG performance score, and the liver function. It is divided into a very early stage, intermediate stage, and advanced, and the last stage. So what that means is, if you have a very small tumor burden in a preserved liver function patient with good performance status, you could potentially go for curative treatments. That is very early stage. Similarly, in early stage, where tumor burden is a little more, then also resection and curative treatments are possible. But as you go to the intermediate stage, where it is multinodular beyond the early stage criteria, but you still have preserved liver function as well as good performance status, then there it's kind of a heterogeneous group where based on tumor morphology, and the patients can either get a transplant or a local regional therapy or a systemic therapy. That's kind of a very heterogeneous group. And then in advanced stages where there is extrahepatic spread or portal vein invasion with relatively preserved liver function and kind of okay performance status, then the systemic therapy is the answer. And in the last stage, of course, it would be best supportive care. This also gives expected survival, and also gives a concept of transplant, this treatment stage migration, which is very important. It kind of says that if with treatment there is tumor progression, or if there is failure of treatment, then you could consider next higher category of treatment. So that gives certain element of individualization. It also says that tumor board meetings are very important. That is again a point to highlight, because with tumor board meetings, you have the treating physician in place along with multiple other specialists who know what is the nutritional state of the patient is, which is not covered here, comorbidity, which is not covered here, frailty, age, social status, human values, and so on and so forth. So it also paves way for individualization of treatment. Next, please. In the Indian scenario, INSL has modified the BCLC staging for use in Indian patients based on the more evidence that is available. It is kind of there are certain differences from BCLC staging, and that are very important. One, at the top you can see it is hepatocellular carcinoma in the patients with liver cirrhosis, while the other classification BCLC says it's just hepatocellular cancer. So that distinction is important. It divides C in C1 and C2. Emphasizing that in C1, where there is just a portal vein invasion, there could be localized this local regional therapy that could be effective. It also divides D in D1 and D2, where D1 can potentially have liver transplant, if they meet the criteria. It also gives you kind of options of downstaging, especially in B, and it also gives you an option of combined therapy in certain categories. Again, treatment stage migration is emphasized here. So I think this is actually a good classification to be used in Indian scenario.
Thank you, Dr. Ankur. I think another point to stress here is that prognostication should be something that is an integral part of your workup. And I think, again, we've spoken about this. You need to look at the tumor characteristics, you need to look at the tumor markers, you need to look at the liver function status, and also the performance status of the patient, where you're going to think about going ahead and resecting or transplanting these patients based upon their liver function and their performance status. And again, the role of tumor markers needs to be emphasized, and this has now become a part of each and every selection criteria or the criteria for transplant, or even for resection, or for intervention radiology or radiation oncology. Dr. Tarun, quickly let's go through the role of PET scan, because there are a lot of questions here, but I would like to take you through the role of PET scan, one in diagnosis, in staging, and also in terms of the different types of PET scan which is available. So if you could just quickly take us through the PET scan part.
So I think PET scan play less role in diagnosis, but they rather play more role in staging as well as in prognostication. So I'll take you through these slides. So this shows you that there is a large HCC with in the left femur. You can see that there is a metastatic lesion there, which is 𝐹TG-AVID. So this is showing you a metastatic lesion. And if you go on the next slide, on the right side is the bone scan. So this lesion doesn't light up on the bone scan. You see, this lesion is not in the bone. It's not in the cortex of the femur. This is rather in the intramedullary component of the femur. So this lesion did not get picked up on the bone scan. So that's the importance of including PET CT scans for staging purposes. Although it's not a very standard tool for diagnosis. And why so? I would say that the HCC frequently exhibits very low FDG uptake. Most of the times, around 50% of the times, these lesions do not show you an uptake. So hence, FDG PET is not generally considered very useful for HCC visualization and is not currently a recommended standard imaging modality for the diagnosis of HCC. Now, going through this narrative review, which has come from the Chinese group, we have found that it's a very good tool for staging, for prognostication, and for choosing the treatment options. So the morphological characteristics alone do not incorporate the biological behaviors. They do not accurately predict the aggressiveness, the prognosis, and the risk of recurrence. And PET CT is a very valuable tool for reflecting the biological status of the tumor aggressiveness, because it's highly associated with the tumor pathology and the response to the treatment, and thus it helps in staging and prognostication. FDG PET has shown very promising results with regards to detection of extrahepatic metastasis. This is because FDG picks up wherever there is hypoxia. So the more the aggressive the tumor is, there is more glucose utilization in the microenvironment, and it creates an anoxic state or a hypoxic state, which correlates with the FDG avidity which happens there. So uptake of FDG by HCC is significantly and positively correlated with the tendency for extrahepatic metastasis. Next slide. So we have seen that the lesions which are FDG positive, they tend to have a very high risk of recurrence. The tumor doubling time in some studies has also found some positive association with FDG uptake. So I would say that HCC with the low FDG uptake, there is a longer progression-free survival and overall survival, thus indicating that the FDG avidity of HCC was significantly correlated with the clinical outcomes. So the take-home message is well-differentiated HCCs will show you less FDG uptake. Highly differentiated tumor cells have slow proliferation, and they show you less uptake because the rate of angiogenesis remains high. Poorly differentiated liver cancer tissues, there is excessive proliferation. The rate of angiogenesis cannot keep up. Hypoxia is created, and that is depicted in the form of high FDG uptake. So this also indirectly, last slide, it indirectly reflects the high FDG uptake in undifferentiated and poorly differentiated HCCs. So next. So we have, looking at these two studies, one of them done at our center, we have found that for choosing the patients for liver transplant, LDLT for HCC combining FDG PET findings with clinical factors could effectively select HCC patients who are candidates for LT. Because LDLT with with HCC UCSF criteria, AFP, FDG PET, avidity are used in deciding treatment strategy in HCC patients for LT since they predict recurrence. So this is a very important point here. Next slide.
So I think, Tarun, I just wanted you to make a short comment on 18F FDG PET versus FAPI PET, because this is something that has come to the fore. And
Yeah.
for want of time, I would like to just get you to quickly tell us about what do you think is the current role of FAPI when it comes to PET scan?
So Prashant will quickly run through these slides. So in this slide, I would highlight the fact that FAPI is a new class of PET tracer and it targets the tumor microenvironment. So this is the fibroblast activation protein inhibitor, which gets activated in the microenvironment of around the tumor. It does not focus, does not target the tumor cells itself. So it just targets the microenvironment of the tumor. So what are the advantages? The advantages are that there is a very high sensitivity and specificity as we have seen with the FAPI PET CT scanners. The 50% of HCCs are typically hypo or isometabolic compared to normal liver, and they show poor FDG uptake. Now, this poor FDG uptake, as we saw, was because of low FDG6 phosphatase activity, because of low glucose transporter expression. So they are generally found in, which is generally found in well-differentiated HCCs. That means that only poorly differentiated HCCs were picked up on FDG. But on FAPI, most of the sensitivities, most of the HCCs get picked up. That means the sensitivity of FAPI PET is 96 to 100% compared to 50 to 65% of FDG imaging. And the sensitivity is also more when we look at lesions less than 2 centimeters. So this is 69% as compared to 19% in FDG.
Sure.
So the well or moderately differentiated HCCs also get picked up on FAPI PET. This is around 83% as compared to FDG, which is 33%. So there is higher SUV max and higher tumor to background radiation values found with the 18F FAPI PET compared to 18F FDG PET.
Sure.
Next slide. And another factor that FAPI is helping us is that it has picked up there's a higher detection rate for the primary intrahepatic lesions and for the lymph node metastasis. While for the distant metastasis, still the FAPI as well as the FDG, they are almost comparable.
Sure. So Tarun, I would just skip this and come to the fact that, I think there is definitely a future role for FAPI PET. But as of now, the data on FDG 18 PET is much more robust, especially in terms of the liver transplant scenario.
I agree.
Thank you. So I think a thorough pre-transplant workup is required to rule out extrahepatic disease, and that's the whole aim when you go to prognostication of these patients. And we've even gone up to the extent of doing EUS FNAC of suspicious lymph nodes, and we've published this, where it is absolutely essential to rule out extrahepatic disease or metastatic disease before you take these patients up for transplantation, and this is our protocol. So finally, it comes down to choosing the right strategy for the right stage of the tumor. Since we've had 2 talks where we have spoken exclusively about transplant as well as for systemic therapy, I'm going to limit myself more towards the radiation oncology part, the IR part, and if at all there is role of resection or surgery in patients who are undergoing some sort of a curative treatment. And we all know that in the early stage or in the very early stage, ablation is something that is put forth, resection also is put forth, and transplant is also put forth. Now, let me come to the intervention radiology. Dr. Baijal, do you want to tell us about ablation in early and very early HCC?
Yeah, so very simply put, we understand that the survival benefit of resection and RF for very small lesions, that's less than 2 centimeters, seems to be matched. As the tumor starts growing bigger in size, we realize that RF starts becoming weaker because we're not able to achieve persistent and predictable ablation volumes. And therefore, there has been a move to microwave, which has proven to be a more robust and repeatable method of generating heat as a ablative tool. But more than 4 centimeters, but I think if you look at practice, it's actually 3 centimeters, because you want a R0 ablation, which means going at least to 4 centimeters for a 3 centimeter tumor. So 3 centimeters effectively would be the size where we would hesitate to go beyond when considering ablation. Now, the thing is that if the patients need bridging, more or less, I think if it's more than 6 months, certainly one of the therapies have to be done in very early. And interestingly, the concept of stage migration that came up in the last BCLC now allow us to look at alternative treatments and not only ablation, which was the only IR-based strategy showing in the algorithm earlier, in the earlier BCLC. So if you look at NASL and BCLC now, because of the legacy study where the overall response rate was so high, the median size of the tumor was 2.7 centimeters, though it ranged from 1:8 centimeters. It's really figured that if you do not wish to use ablation, one can use TACE and Y90 as well. And if you look at the Korean recommendations, they were more TACE dependent. The legacy got us to TARE. And the reason why TARE has started figuring is its ability to achieve complete or extensive tumor necrosis, which has been very well correlated with the chances of recurrence. So if you can achieve high levels of tumor necrosis, you limit the chances of recurrent disease, and that's achieved if you have appropriate dosing. And in this study, it was 400 using glass spheres. So if you do the therapy right, you can really get it. So, but a very frequently asked question is that if you have to really do transarterial therapy, should it be TACE or should it be TARE? So this was a comparison that happened in which they did selective chemoembolization, that is TACE, or radiation segmentectomy using Y90 for small tumors. And if we look at the complete response, the overall response, and the time to secondary therapy, meaning a second treatment was required, everything was so overwhelmingly in favor of radioembolization that becomes now the preferred method of treating for small HCCs if you are looking at treatments outside of ablation.
Thank you, Dr. Baijal. I would then go to our radiation oncologist. And Dr. Shyam, what would you like to say about the emerging role of radiation in these patients?
Good evening, everybody. Thank you, Dr. Prashant, for the question. So the role of radiation, especially the SBRT in HCC, if you see in the early and very early stage for patients who are eligible for transplant, but they cannot go transplant, they are not, they don't have a donor. So the role is in the bridge therapy. Second, coming to the patient who are not candidate for transplant, and in those patients, like in combination with different. So in this slide, I have summarized all different international guidelines except the BCLC, which have removed SBRT, but all other guidelines like AASLD, ESMO, NCCN, ASTRO, Hong Kong, PODI3, ISRS guidelines, they have all mentioned the role of SBRT in different stages. If you see in the early stage, very early and very early stage, the AASLD recommends that SBRT and is alternative to ablative therapy, SBRT and TACE, in fact, the previous slides. So if you see the topmost box, the ESMO and the NCCN, they also recommend that if arterial therapy is planned, SBRT is a potential first-line therapy for early and very early risk. And the ISRS International Stereotypic Radiosurgery publication, in their meta-analysis and guideline, they have suggested SBRT is one of the first line for tumors less than 3 centimeters. And now coming to the BCLC-B intermediate.
We'll go to the BCLC-B later on.
Right.
Let's stick to the early stage now.
Okay. Early stage. So this is a meta-analysis of prospective phase 1, phase 2 studies. They have shown a very reasonable control rate of around 80 to 95% local control at 2 to 3 years with SBRT, which is comparable to the RFA and TACE, and sometimes better as compared to RFA for larger tumors. As recently Dr. Bejal said, this is a Michigan study published almost 10 years back, which is a retrospective study. It has compared SBRT as compared to RFA in tumors in early and very early. Although the patient in the SBRT arm, they were very richly, they were rich with poor factors like poor LFTs, recurrent diseases, poor prognostic factors were with SBRT. But still, you could see a very drastic difference in the outcome between SBRT versus RFA in tumors of early and very early. And this difference was more when the tumor was more than 2 centimeters. So next slide, please. So this is a meta-analysis of studies comparing SBRT versus RFA. These are all prospective studies, phase 1, phase 2 studies. They've shown that the overall survival is similar between RFA and SBRT, but the recurrence-free survival, that means a local control at 2 and 3 years was significantly in favor of SBRT as compared to RFA. Next, please. So this is our Toronto study, which has used SBRT as a bridge. So in this study, this is also a retrospective study. It has compared SBRT versus TACE, which is a middle group, and third is RFA group. So they have seen at the dropout rates. So in SBRT arm, the dropout rates were around 16%, and in TACE 20%, and RFA 16%, statistically insignificant. So all the three groups had similar dropout rates, and 5-year survival from the time of transplant was similar, almost 75% in all the three groups. So this emphasized the role of the SBRT as a bridge therapy. Next slide, please.
Okay.
This is a prospective study, prospective study comparing the SBRT, TACE, and HCC as a bridge therapy in early and very early stages. And they found, you can see the blue vertical graphs that correspond to the tumor control of SBRT. So SBRT has shown us much better local control as compared to TACE and HCC in this prospective study.
Okay.
And next, please.
Okay, so I'll just, okay.
Yeah, this is there was the least amount of dropout with SBRT with the higher PCR rate as compared to other therapies.
Okay, thank you. And I think from there, from the ablation and the SBRT, I think we need to remember that ultimately, if you want to improve outcomes in patients with HCC, old is still gold. We have spoken about transplant. We know the general transplant criteria. But what is the role of resection in very early and early stage HCC? Dr. Kamal, if you want to tell us about this.
Yeah, hi. Good evening, everyone. I hope I am audible.
Yeah, we can hear you.
So this is the BCLC classification for choosing the treatment modalities. Next, we have spoken about this in detail. So for the considerations in HCC treatment modalities, to individualize the treatment options, especially the surgical treatment options, what factors we need to consider is whether the patient has got cirrhosis, non-cirrhosis, tumor size, number, vascular involvement is there, extrahepatic spread is there or not, and the performance status. Also, we need to consider the tumor biology, whether it's a well-differentiated tumor, aggressive tumor or not, because there's a risk of recurrence, especially in cirrhosis, if you go for resection. And the last one, the modality, whether it's like Western countries, America, Europe, where the DDLT option is there, TDLT is preferred modality of transplantation as compared to the Asian countries where LDLT options are quite available. And in hepatobiliary units where transplantation is not available. So there, the surgeon may choose resection over the transplantation. Next, please. So considering for very early and early stage HCC, EASL and ASLD clinical guidelines, they recommend resection as the treatment, as the preferred modality for these early stage HCCs. To consider resection in HCC, we need to assess the liver function, how well the liver is preserved, that can be done with CTP score, MELT score, LB score, and different functional imagings can be done. Also, we need to consider whether there is a clinically significant portal hypertension present. That can be said when HVPG is more than 10, or there is a massive splenomegaly or ascites on imaging, or the platelet counts are less than 1 lakh. We also need to see whether the resection is to be done as a minor resection or major resection. What is the future liver remnant? Ideally, it should be more than 40 to 45%. And definitely the performance status is also a key factor in deciding for the treatment resection. So, clinically significant portal hypertension and child B score, child B cirrhosis is not absolute contraindications when there is a limited resection. That means less than 2 segments if you are removing, especially if it is done in a minimally invasive manner, that is laparoscopic or robotic liver resection. But for a major liver resection, clinically significant portal hypertension and child B is an absolute contraindication. Next slide. So this is just an algorithm to tell in early stage HCC, when you have a single lesion, child A patient with no clinically significant portal hypertension, surgical resection, yes, can be offered. But if there is child B, advanced child B, or clinically significant portal hypertension, the best available option is liver transplantation.
Thank you, Dr. Kamal. And I think that there are obviously several influencers on this treatment decisions between LR and LT. And you've summarized it very well as to when we would be going ahead in terms of the background of liver cirrhosis, the presence of portal hypertension, the tumor size location, as well as the fitness of the patient. And there are some, obviously, these are things that you've already spoken about, and we also need to look at the risk of recurrence. I'll come to you a little later on some other aspects. I'm going to run through these a little bit and probably skip some of these particular aspects where we are talking about a resection in these particular cases. But I would then go to transplant in this early transplantation setting. And again, this has been spoken about before, that whether it's the BCLC or whether it's the INASL, we've already spoken that transplant should be one of the options in terms of conventional criteria, whenever there are conventional criteria, and when the patient is an optimal candidate, whereas resection can be done if you have an optimal surgical candidate. This is again an important concept, that HCC will always come in a diseased liver, and HCC is a multicentric disease. So if you want to remove the disease in its entirety and you actually want to do an oncological cancer surgery, probably the best option is a transplant in these particular patients. And this has been shown by meta-analysis, where if you will see, the liver resection had a poor overall survival. They also had a poor disease-free survival. Although the overall survival was equivalent here, the risk of recurrence remained excessively high, almost threefold with resection as compared to transplantation. And we also showed this even in a single tumor, less than 5 centimeters in size. There was a significant difference in overall survival with upfront primary liver transplantation giving you much better overall as well as recurrence-free survival, even for what is called the early stage of HCC. But yes, I think that although it is ideal to do a transplant in all these patients, it's not always possible because of the dearth of organs, and therefore liver resection should be considered for reasons of graft shortage as well as various other things. There is this strategy of salvage liver transplantation where you do a resection first, and if you have a recurrence, then you go ahead and do a salvage liver transplantation. But the problem with this, and this is something that was shown very clearly in this paper that we published in Annals of Surgery, that the problem is that you are losing those patients. If they recur, they sometimes recur outside the liver, and therefore you're not able to transplant them once they recur after transplantation. And hence, it was very clearly shown that if you had primary liver transplantation, the outcome in overall survival as well as disease-free survival was much, much better as compared to doing this procedure of salvage liver transplantation. And that was mainly because you lost about 34% of patients only remained actually transplantable if they had recurrence after a resection. So it is the best oncological option in a cirrhotic patient, transplantation. It's not always possible. Logistics, feasibility, possibly similar outcomes, as Dr. Kamal said, with resection are available, and therefore you may go to ablation or resection in these particular patients. Dr. Soin has spoken in detail about this group of patients, the intermediate as well as the advanced stage of HCC. And we also said that till 2022, what was offered to these patients was TACE and sorafenib. What we attained was a 3-year survival of about 10 to 40% in these patients. And we always said that there was no resection or transplantation indicated. However, this changed in 2022, and even in intermediate stage, the transplant option was given. As we have spoken about, the Puri 3 recommendations spoke about using transplant in these patients if we could migrate them, and they created a stage B1. Now, in the intermediate stage of HCC, Dr. Baijal, what's the role of intervention radiology? TACE versus TARE, which is better, and would you just summarize that for us?
Right. So I think easily put, this is the commonest question that we address to ourselves. If you put economics aside and talk about what is the efficacy of these treatments, it was best answered by this randomized control trial which happened. And in this group of patients, the Y90 result was so much more superior when it came to evaluating the time to tumor progression as well as the overall survival, that the study was terminated. So effectively saying that if you can do Y90, that should be the preferred way to treat. And this was matching it with DEB-TACE, which at this point is the standard of treatment transarterially if chemoembolization is being done, not the CTACE.
Fantastic. So I think very clear. Dr. Bisht, what is the role of the radiation oncologist here when it comes to intermediate stage HCC?
In the intermediate stage, the patient now, as we have seen in the Puri 3 and other guidelines, so patients which were beyond criteria, now they can be transplanted. So provided effective down reduction can be achieved, it can be achieved along with combination of the IR guided therapies. So SBRT, few now publications are coming up, especially the prospective studies, as we can see 2 studies which have shown that there is a role of SBRT if the tumor is around 5 to 6 centimeters, but not very large tumors. They can be downstage because the liver is already cirrhotic. So that is the limitation, but around 5-6 centimeters tumors, so we can downstage. And in this study, we have seen that around 80% were successfully downstage for the transplant. And the other is in the intermediate stage, along with the IR therapies like TACE, mainly after in combination with TACE after TACE failure. This is a retrospective study which have seen that after incomplete failure, after the failure with the TACE, then SBRT is effective with giving a local control at 3 years of around 91% with OS of 72%. So that means it can be used along with combination. There is one more prospective study, which is the next slide. This is a randomized prospective phase 3 trial comparing TACE failure RETACE versus TACE failure SBRT. That means SBRT versus RETACE. And although it was prematurely closed, but it has shown a very huge difference in favor of SBRT as compared to the repeating of TACE in the patients who are intermediate stage and they are being planned for downstaging. Next, please. So this is a systematic review and meta-analysis, which are also shown that TACE and SBRT combination versus TACE or repeat TACE is better as compared to repeat TACE. So we can see in this forest, both these diamonds and the local control overall survival are in favor of the combination of SBRT and TACE.
Thank you. Dr. Kamal, is there any role of resection in intermediate stage HCC?
Yeah, so in intermediate stage, if you consider EASL and EASLD guidelines, resection is not recommended. But in Asian guidelines, resection is recommended for intermediate stage, especially like intermediate stage is multinodular HCC. So when it is well defined, localized to one side of the liver, then yes, resection can be offered when in a setting when liver transplant is not an option, or the organ is not available. So there was one meta-analysis done of 18 studies which showed, can we go to the previous slide?
Sure.
So there was one meta-analysis done of 18 studies which showed, which was comparing liver resection versus TACE. So which showed liver resection had a better oncological and better overall survival as compared to the TACE. And but in liver resection, when you choose the liver resection modality, the risk of recurrence is quite high. That can go up to 50 to 70% in 5 years. So to consider neoadjuvant or adjuvant is one thing that I think subsequent people will be talking on this. Next slide.
So this is liver resection for intermediate stage, the meta-analysis. Dr. Kamal, are you able to see this?
Yeah. So this is what I was saying. Different studies were considered, and which showed surgical resection has better outcomes as compared to the TACE.
Fantastic. So I'm not going to go into details of this because I think we need to finish in the next 5 to 10 minutes. Liver transplant for intermediate stage, I think we've spoken in detail. Dr. Ankur, I think I'm just going to skip this for now because we've spoken about the conventional criteria. We've spoken about the INASL modification, and you very clearly, when you spoke about the staging, spoke about applying the stage migration as well as the use of the multidisciplinary board. About the Medanta criteria, Dr. Soin has already spoken about this. He has told us about the independent predictors of a worse recurrence-free survival and this risk stratification. So I would just avoid that particular repetition, if you would allow me. And then I think these are two papers. One is the consensus document that we came up with, and this is the example of using tumor biology in expanded criteria that I think those interested may go into in detail. The concept of stage migration, again, Dr. Ankur has very nicely explained this, that you could actually do an initial TACE, you could successfully downstage the patient, and then you could go to transplant in these particular patients. I'm going to go quickly to the advanced stage, and Dr. Narendra, again, for want of time, since Dr. Neeraj has elaborated on this in detail, I'm just going to say that we've spoken about all these criteria, and INASL does not recommend the use of systemic therapy if you have a CTP more than 9. Dr. Neeraj spoke about the ALBI score, the reflex study in very much detail. Do you want to comment on these things, Dr. Narendra? Because we always see the rosier part, but there are some things that do happen with this systemic therapy.
This slide shows difference between lenvatinib and sorafenib. This data is based on this reflect. So any grade toxicity, any grade of rash. So rash was very common with sorafenib. It was 26% with lenvatinib versus 52% with sorafenib. And severe rash, grade 3 or more, it was 3% versus 11%. Main adverse event with lenvatinib is hypertension. That is less common with sorafenib, and this rash is more common with sorafenib. That is less common with lenvatinib.
Thank you. So again, this OS, PFS, we've gone through all this. The IMBRAVE study again was about Atezo-Bev versus sorafenib. Again, Dr. Neeraj has spoken in detail. He's gone through the Himalaya trial and the STRIDE trial. And again, in the NASH population. Do you want to make a mention of this in the NASH population, Dr. Narendra?
While in viral etiology, immunotherapy is definitely better, associated with better overall survival and progression-free survival, but NASH, there is no good data. And in fact, lenvatinib is similar, or some of papers have shown that it may be better than immunotherapy. Immunotherapy is very costly as compared to lenvatinib. So patients with NASH-related cirrhosis are not good candidates for immunotherapy.
Thank you, Dr. Naren. So just to make those particular important comments or those important highlights of whatever we've learned over the years with this sort of systemic therapy. And this again is the BCLC staging algorithm. I just want to go to the radiation oncologist and Dr. Bejal from the IR point of view for advanced stage HCC. Because in INASL, we have spoken about TARE, we have spoken about SPRT in this particular stage as well. Dr. Bisht first.
In case of like advanced, when there is a portal vein thrombus, SBRT has a very important role. It has a very important role in the downstaging, especially in terms of taking the. I think there's some background noise.
Dr. Charles, could you please mute Abhilasha? I think. Yeah, go ahead, Dr. Sham, please.
So SBRT is a very important role in the portal vein tumor thrombus because it has a potential, because portal vein tumor thrombus, their volumes are generally much less as compared to the primary HCC. So we can have a very high dose. So it can make the enhancement, loss of enhancement. Sometimes it can cause recanalization also in this way. And definitely there are a lot of publication, one from multiple from Medanta team, one from you in transplant, which I have shown on the upper right, and there are two other. So it has, in case of advanced HCC, along with the systemic treatment, it has again a role in prolonging the life, improving the quality of life. This was an NRG trial comparing sorafenib versus SBRT, and it has shown that SBRT is a phase 3 randomized study, which has shown that overall survival and PFS was significantly better with SBRT compared with the sorafenib. And over this, the SBRT, as discussed by Dr. Sehgal also, it has the potential to improve, make the cold tumor hot, and it creates new antigen. That means with SBRT, we creates the multiple new antigens which help the immunotherapy to work better. This has been seen usually in lung, other renal cancers, other cancers. So definitely in HCC also, it has the potential to create the cold tumor as hot and further improve the work of immunotherapy.
Sure, thank you. Dr. Bejal, your last word on advanced tumor and use of IR.
So just wanted to share with you that I think it's the most powerful tool to control and downstage advanced HCC. And like Shyam mentioned, I think combination therapies, and like you mentioned, in our experience, adding both of these has definitely a synergistic effect, and we can pull down patients and downstage them to get them to get the benefit of transplant. And our data here evaluated our experience, and we looked at what really can predict the response to treatment when we are doing Y90. We had a large number of very large tumors. You can see nearly half the patients had portal vein tumor thrombus. If you look at the overall objective response rate, it was nearly 90%. And if we can go to the next slide, our data told us that the mean tumor absorbed dose of 208 gray, and if you have D50 basically means at least 50% of the tumor volume got how much radiation? It was 193 gray. And if you look at V150, that is what volume of tumor got at least 150 gray, it should be 60%. If this combination held true, we were going to achieve a complete response. So trying to say that dose is so important, and it's been validated across in so many other studies with patients with advanced portal vein tumor thrombus up to VP3, that you can achieve much better outcomes if you were to do a very focused, personalized Y90 therapy versus the conventional way of doing Y90. We won't go into the details of dosimetry, but trying to say that personalized, individualized, high-dose ablative Y90 is the key to get best outcomes. So there's still sometimes a simmering discussion that can we really do TACE even for patients with portal vein tumor thrombus? And this study actually looked at patients who had vascular invasion as well in both groups, though of course they were much more in radioembolization, but I think it's just so much obvious that Y90 is proving to be superior in this group as well as compared to CTAs. We won't go into this. This is Prashant, your data, and we've done this many times in today's session. Just trying to say that effectively downstaging using Y90 makes patients behave as if they had no PVTT initially. So those two cohorts are now beginning to look very identical. Thank you.
Thank you, Dr. Baijal. And Dr. Kamal, just one quick word from you. Is there any role of resection? We'll not go to liver transplant because we've already spoken about that. Is there any role of resection in these patients with advanced stage HCC? I know there is zero role as far as the West is concerned, but what about the East?
Yeah, so resection definitely can be considered when liver transplant is not an option available to the patient. And in advanced stage, it means you have a HCC with portal vein tumor thrombus and or you have got extrahepatic disease. So extrahepatic disease, no resection, but with HCC, with PVTT, these patients can be offered liver resection, especially if I have to summarize, especially in VP1 and VP2 PVTT with HCC, liver resection can be given an option. And I would say definitely there is a role of downstaging them with the help of TACE or radiation SBRT.
Okay, thank you. I think I just want to conclude here by saying that we looked at this group of patients where we spoke about transplant, and this was our protocol for the same. Dr. Soin has elaborated on this. This is the updated data. There are some caveats. This question is often asked, is it possible for every patient to be downstaged and then transplanted? And actually, it's only 50 to 60% who can actually be transplanted after downstaging. Number two, the patient needs to be a CTPA with a good amount of non-tumor volume. It is absolutely essential to have an adequate waiting period after successful downstaging. It needs to be done by an expert IR and radiation oncologist. It is how you deliver the SBRT or the TARE and what dose you give that is very, very important when it comes to actually going ahead and being able to transplant these patients. There are two last slides which I would like to say. These patients are probably never for LT. Those patients who have extrahepatic disease, those who have macrovascular invasion, you should not do an upfront liver transplant in them. You should not transplant a patient who has a failure of downstaging with macrovascular invasion. And also, if it does not conform to the triple equipoise concept in LDLT, these patients should not have a transplant. These are relative contraindications. Hepatic vein tumor thrombosis is very different as compared to portal vein tumor thrombosis. So someone who has an HVTT, you have to look at with a great deal of suspicion and not really go ahead and transplant these patients. And those who have very high levels of tumor markers which are not decreasing or they are increasing on the waiting period, you should not transplant these patients. Finally, I think we have reached an age of transplant oncology where you cannot have one rule for each and every patient. You need a multidisciplinary board who sits and decides what is best for each individual. And I think with a multidisciplinary approach, we can help personalize therapy and obtain optimal outcomes in these patients. So thank you very much to all the panel members and thank you very much for staying with us, whoever is still with us for this panel discussion. Abhideep?
Prashant, can you quickly take the questions in the chat box in the next 2-3 minutes so that we can wind up after that?
So I think we started off with a question. I'll take the first one. I think Dr. Vibha Verma asked us a question about the role of, if you would consider any number and any size, then what would you go in terms of the algorithm if you had looking at alpha fetoprotein? And I think Dr. Vibha, Dr. Soin did show this, that we consider some patients for upfront transplantation, some patients who are moderate risk for downstaging and then transplantation, if that is possible, because in some patients, because of lack of liver function, good liver function, you're not able to actually downstage these patients or to give them therapy. And finally, I think high-risk patients are not for transplantation. Dr. Abhideep, you can go to the next one.
How relevant is BCLC in Indian LDLT prominent scenario?
Dr. Soin, do you want to take that question? I'm not sure Dr. Soin is able to unmute. Dr. Neeraj,
So,
do you want to? Yeah, Dr. Soin, please.
See, the thing is, the BCLC, you must understand, has been originally made with the DDLT and conventional criteria in mind. In fact, they have been over-conservative initially because they are pretty much writing off people with poor performance status, even if they have treatable cancer. This is what the original BCLC was. Then they have evolved to include higher stages, the intermediate stage into the ambit of transplantation by extending the liver transplant criteria. And for the Indian scenario, there are two things which are different. One is that it's largely a living donor liver transplant system, right? And the second thing is that I think we get tumors very late. So the people present very late to us. And actually, if we don't evolve protocols that will treat and even potentially cure locally advanced disease, then you're actually going to leave a lot of patients high and dry, and they're all going to die very soon in a few months, right? So I think these are the two ways that BCLC is different or is not directly applicable, but what is applicable to us is definitely the INSL modification of BCLC criteria, which we have amply explained in today's session. And suffice it to say that when you're talking about early cancer, BCLC is fine. But when you're talking about locally advanced cancer, then you should definitely look at downstaging, which the entire world is doing across LDLT and DDLT scenarios. So you should definitely look at downstaging patients with no extrahepatic spread and no major vascular invasion. But as we have shown, and now others have also shown, there are a selected group of patients with major macrovascular invasion who can also benefit with downstaging and transplantation.
I think the next one is Dr. Kaptan, who says, which tumor marker is recommended for prognostication of AFP or PIVKA2? Dr. Neeraj, do you want to take that question, or a combination of any two? We did already speak about it. Any cutoff limits? Dr. Neeraj? Yeah, so again, I think if Dr. Neeraj can't unmute, I did show Kaptan in one of the slides where a combination of alpha-fetoprotein and PIVKA2 increases your sensitivity, increases your specificity. But as I said, 60% of them are AFP secretors, about 40% are not. And therefore, PIVKA2 is secreted by those probably 40%. And therefore, if you combine the two, you're going to get better results. Normally, alpha-fetoprotein, which is more than 1000, is considered as a cutoff where you would not really think of transplanting these patients. But now, if you're able to downstage them and keep them at a lower level for a longer period of time, you will be able to. There is again not a cutoff for PIVKA2 per se, but if you have a delta PIVKA2, that means a falling PIVKA2, and it remains there for a longer period of time, I think that is where you would set it. Rather than one limit, you will think of a delta. Dr. Abhideep? Next one.
Yeah, I mean, next one is for LR3-4 lesion. Is there any role of additional MRI, DWI cut for characterization of the lesion? What would you recommend? Contrast MRI versus CCT? That's for Dr. Tarun.
I'll take that one. I actually answered that question in the chat itself. So
Okay.
LR3-4, the problem is LR3-4 is basically if you get one of the criteria plus the lesion is less than 2 centimeters. So if it's 1 to 2 centimeters in size, the diffusion weighted imaging actually does not really help us. Although we try to include diffusion weighted in all our sequences, all our MR scans, contrast enhanced scans, we try to include one diffusion weighted sequence. But the problem is the lesion which is between 1 to 2 centimeters, the sensitivity of showing restricted diffusion in those lesions is relatively less. So although we are trying to work on it, I mean, we try to include diffusion weighted definitely, and dynamic MR obviously scores over dynamic CT 3 to 4%. So I think dynamic MR should be done if you want to really find out, get that answer, is it really LR3 or LR4? But as of now, the techniques are evolving, so we are still struggling with that.
Okay, thanks, sir. Next question for Dr. Soin. For HCCs within Milan or UCSF with no extrahepatic disease, no vascular involvement, but high alpha-fetoprotein, is there any role of downstaging before LDLT? I think you've already answered. And how do we go about that?
So when you say high, how high? I mean, if it's like 50,000, then I would seriously explore systemic spread. I would seriously explore, I would go after every lymph node that shows up on a PET CT scan and FNA it. And I would obviously look really hard for a, vascular invasion, because you don't get very high AFPs like that without that, right? But if you're talking about something like 1,000 or 2,000, then I think it's situational. And we have shown in our tumor biology paper that Prashant and I alluded to earlier, that even a pre-LT of less than 100 and a more than 100 actually makes a difference. It becomes a risk factor. So if possible, if logistically and situationally possible, I would still downstage so-called a high AFP. I would not consider downstaging it as absolute prerequisite before transplantation if there's no major vascular invasion, and unless it's in the tens of thousands.
And
would you ever consider? Would you ever consider downstaging when the tumor is within UCSF or Milan with a alpha-fetoprotein, say less than 50, or you would just go for upfront transplant?
Less than a 50 and within Milan. Why would you downstage?
I mean, would you ever consider downstaging in that kind of situation?
No, that would not be downstaging. I mean, if the patient was waiting for a cadaveric transplantation, that would be like a bridging therapy, but it would not be downstaging.
And if on a bridge you see a complete response, if someone has done a bridge or the treatment and there's a complete response even after follow-up of 6 months, would you transplant this patient?
Yes.
And I would just like to make a comment here on the difference between downstaging and maybe neoadjuvant therapy here, because even if it was alpha-fetoprotein, which was about, say, 200 or 250, downstaging would be that you've actually brought this down to a level which you have predetermined to be brought down to a particular level. So one needs to recognize the difference between downstaging and neoadjuvant therapy. You cannot say downstaging for someone whom you've just brought down from 200 to 100 and immediately the next day you've transplanted him. That is not downstaging. Downstaging means you bring it down to a particular level, keep him on that particular level, and that is what conventionally downstaging has meant for all these years when you talk about DDLT and waiting list, etc. So if you were to say that, because your alpha-fetoprotein was high, it was about 250, you did a TACE, and then you found that the alpha-fetoprotein came down to 150, and then you went ahead and transplanted him, straight away, I would say that would be some sort of a neoadjuvant therapy rather than doing a downstaging procedure. And that's what we said in our moderate risk category. If you have only one of these risk factors, that means only alpha-fetoprotein was high, and you had it within UCSF criteria and you had a non-avid tumor, I would probably do some sort of a neoadjuvant therapy and then not really wait for, say, 3 months or 6 months to see if the alpha-fetoprotein remains stable, because you would then probably lose a chance of transplant because you may get some patients who are off the list. So we need to make that distinction, and that should be clear even to the students and the younger people.
Right, and that actually answers the next question as well, how long you should wait after. So there is a question, would you consider doing a baseline ctDNA that can be used for follow-up, like the way you do a CEA for colon cancers?
It's not standard. So, I mean, as a research protocol, yes, but certainly not as a standard clinical protocol, it's not done yet.
Right. And as far as the metastatic workup, PET scan or bone scan plus HRCT, any combination of that?
I would do a PET CT, but do a PET CT with a focused HRCT.
Right. And
as in thin slices and that kind of thing.
Right.
So I think
Is
there's a
there
question
a role?
on, I think one of those questions, Abhideep, was already answered. We can go to the next one. Increased risk of HCC in MASLD. So surveillance is indicated or not? I think Narendra answered that, but I think this
Already,
is
yeah.
a question that is high in the minds of everyone. It's not really recommended at present with no cirrhosis, but in those who are at high risk, and then we can go ahead with that. I think Naren mentioned that as well. Is there a role for repeat SBRT if tumor recurs after a good response on PVTT getting converted to bland thrombus, but new lesions appear a year later? Can these patients be downstaged further and considered for LT if good performance status or no extrahepatic disease? Maybe I can ask Dr. Shyam Bisht to take the initial part. Is there a role for repeat SBRT if the tumor recurs after good response on portal vein tumor thrombus getting converted to bland thrombus?
This question I understand either whether there is a recurrence of the tumor thrombus or a recurrence of the HCC. In both the scenarios, especially in the if there is a PVTD recurrence, we can definitely do. If there is a HCC recurrence after downstaging by with IR modalities, if it is a small size, maybe up to 5 centimeters, we can again attempt for the SBRT. It can be is doable.
So we've also done this in our downstaging protocol. I just wanted to mention that suppose you've initially done a tear and an SBRT, you waited for a period of 6 weeks, repeated the PET scan, and you still find that there is some FDG18 avidity that is there persistent in the portal vein tumor thrombus. We've done an SBRT in many of these patients, and this is actually feasible, and you get good results with it. And we've shown it even after doing a repeat SBRT when we've actually done an examination on the explant. We have shown that there has been a complete tumor necrosis in the portal vein, or the portal vein tumor thrombus has undergone a complete necrosis even at the proximal end where you've actually cut the portal vein. So we've shown that in our paper. I think we've included it there as well. Dr. Abhideep, anything else?
Oh, that sounds good. Dr. Soin, any last words from you before we conclude?
So I think that especially the junior members of this session, attending this session need to understand that all of cancer treatment, but specifically HCC, is essentially a multidisciplinary exercise. And the whole point where Prashant included all of us in this discussion is just to stress that. And no single person actually can make a decision as to the best treatment for a given patient for a given cancer. That's the first thing. The second is that tumor biology is totally in the forefront. You can have a 8 centimeter or 10 centimeter cancer, which is grade 1 on histology and which has a low AFP and a PIVCA, and therefore is biologically a better tumor to treat than a small tumor with portal vein tumor thrombosis and high tumor markers. So biology is definitely in the forefront, and you must take that into consideration while treating these patients. I think the rest has already been said many times.
Thank you, Dr. Soin. On behalf of LTSI, I want to thank you all for being part of this excellent session. And we actually had a truly enriching discussion today from various strategies to manage these patients and multidisciplinary approach to take care of these patients. And thanks a lot for taking out time to discuss all this. And thank Dr. Soin, Dr. Bejal, Prashant, Neeraj, Narendra, Shyam, and sorry if I missed anyone, and really appreciate discussing this at length. And I thank all the participants for asking these questions and making this a really interactive. And we'll be having the next masterclass on liver transplant pathology, and I'll be sharing the details soon. And thanks a lot, everyone, once again, and good night.
Okay, good night, bye.
Good night.